Hello, my name is Dr. Asley. I'm a board-certified, fellowship-trained spine surgeon. And in this segment, I'll be explaining one of the commonly performed surgeries in the world of spine surgery called Anterior Cervical Discectomy Infusion, or shortly abbreviated stands for ACDF. Anterior means front, cervical means the cervical spine area, discectomy means taking the disc out, and fusion, of course, means to fuse the two bones above and below and turn it into one bone. Now, what are the indications for this surgery? Normally, we do these surgeries for continued neck and arm pain. Now, this is a patient's preference in terms of when to do the surgery. As I've discussed in my previous sessions, as surgeons, our job is to actually avoid surgery. And when it comes down to surgery, our job is to tell our patients if we can help them or not. The decision for surgery or no surgery is purely patient's decision. Why? Because a surgeon cannot look at the MRIs and decide how much pain the patient is in. Or we can't look at the MRI and tell what's ahead, what's in future for the patient. That's why the decision for surgery or no surgery is always patient's decision. Even if the patient has an acute event, like has done something, has a severe neck and arm pain, that, for me at least, is not an indication to jump into surgery, do the surgery. Almost 99% of the times, if I have a patient that presents to me with an acute event, I can walk them through that acute event with epidural injections, some steroids or so, and calm them down and bring them back to their baseline. But normally, I would like to wait at least 2 months or so since the start of the symptoms to decide if you have to do surgery or not. As I said, my job is to avoid surgery. And a lot of the patients, actually, they do get better. And even though the disc is there, somehow the inflammation calms down and actually the symptoms go away and there's no reason to do surgery. Unless the disc is large and causing actually symptoms in the spinal cord, in the lower extremity. If the patient has problem with the lower extremities, have a bowel and bladder problem, that's just an indication for immediate, or not emergent, but urgent surgical intervention to decompress the spinal cord. Why? Because if there is an effect on the spinal cord, a good chunk of those effects are irreversible. That's why we have to intervene as soon as possible to make sure that the spinal cords and the ability to walk stays intact. Now, let's say a patient presents to my office, has had 3-4 months of significant pain. We've tried non-operative care, including traction, which I think is the most important treatment in terms of therapy for the neck, physical therapy strengthening, epidural injections sometimes, and the other treatments like medications and steroids or so, and the pain hasn't gone away, and the patient decides that wants to proceed with surgery, then is a candidate for an anterior cervical discectomy infusion. It's one of the mostly commonly performed in the world of spine surgeries. Patients generally do well, and sometimes we do these surgeries as an outpatient. Patient goes home the same day if they elect, or they stay overnight and they go home the next day. This surgery is pretty successful in terms of relieving the arm pain, almost 80-85% of the time. Not as good in terms of the neck pain. Just treating the neck pain is very, very difficult. But its success rate is about for the neck pain is about 70-75%. So it's not a lot lower, but still a bit lower than in terms of relieving the pain in the arm pain. So once we talk about the surgery, once we discuss the risks and benefits of the surgery, and patient decide to proceed with surgical intervention, we put on the schedule the surgery, and proceed with surgery. Now, what is the surgery? When you come into the OR, this is the operating room that we normally do our surgeries. Patient comes in, patient lies down, patient gets secured to the table. And if you can see in this model, this is the head right here. This is the spine. As you can see in this model, you can see really well. These are the bones that are stacked up on top of each other. And these are the discs, cervical discs between the bones. And you can see the nerves coming out. Now, what happens in the pathophysiology in this problem is that at some point the disc goes bad. And as it goes bad, it collapses. As it collapses, the nerves that are trying to come out, they get pinched. Therefore, you get that pain going down the arm. Or, actually, the disc herniates somewhere in the back. And as the nerves trying to come out of the spinal canal, the nerves get pinched, and therefore you end up with symptoms in the arm and the distribution of that specific nerve. So our goal would be to relieve the nerve and reconstitute the height in the disc so we can unpinch the nerves and restore the alignment of the spine. So patient comes into the OR after intubation and going to sleep. We put him down on the table. You make a small incision about this long on either side of the neck. You can go either from the left side or the right side. Some doctors have preference on the right side. Some doctors have preference on the left side. My preference is to go through the left side, unless there's a problem on that side, previous surgery, so then I go through the right side. However, it doesn't mean which side you go on. If the patient's pain is on the right or left side, you can get to both sides. That's why I always tell my patients that even though you have a right-sided arm pain and you incision on the left side, I didn't make a mistake. That's just a preference. You can go to the spine on both sides, either through the right side or the left side. And it's not considered a very painful surgery because you're really not cutting things. You're mostly spreading things. So after you made an incision in the neck, you cut the skin, but then you're spreading. If you can actually put your finger in this interval between the sternocleidomastoid muscle and strap muscle, you can actually push your finger all the way back to your spine. So you basically spread things. Once you spread and dissect this area, you're looking right down into the spine. And if you can focus on the model right here, so let's say we have our own exposure, and let's say we are trying to do this surgery at the C5, C6 disc level, which we always number the disc by the level above and below. So we call the disc C5, 6, C6, C7, and as you can tell right here, this is the anatomy right here. These are the bones that are stacked up on top of each other, and you see that in cervical spine, every vertebrae has a little bit different anatomy because they have different function. But let's say that's the C1, C2, C3, 4, 5, 6, and 7. So let's say you're performing the surgery at the C5, 6 level. You put your retractors in that level, and you get an X-ray. You make sure that you're operating on the right, correct level, and that's very important, of course. And once you do that, you confirm that, then you make an incision, you take the disc out completely, go into the corner to corner, scrape the bottoms out, and you go all the way to the back where the spinal cord is and remove the disc to make sure that all the disc material is gone and there's no impingement on the nerves, as you can see right here. Once you take the disc out and the disc is gone and all you're looking at the space between the two bones, then you have to jack this space open. We have different instrumentation, different spacers with increments that you basically put it right here and almost wedge it, and you actually hammer it just to spread this open, because that's what you want to do. You want to spread this open to unpinch the nerves that are coming out to relieve the pressure on the nerves. Once you do that, if you can see right here, these are actual prostheses that go inside the patient. It's made of PEEK, which is a special type of plastic. You can see this is the actual prosthesis. A couple of things to explain about this is that is a ring. It's formed to look like the end plate of the disc space and has a hole in the middle. As you can see, these are very important. These are all these metal markers. Because this is plastic, when you get x-rayed after surgery, you want to know what you've done, what kind of surgery you've done, where your prosthesis is. You have to have these markers. And patients come to my office and they ask, what are those markers? And this is what they are. This is basically at the front edge and the back edge of this prosthesis and on the corners. So, because you can't see this prosthesis, it's made out of plastic on the x-rays, but these markers will tell you exactly where the prosthesis is and how you've done your surgery, how the healing's coming through. Then, once you've jacked it open, you measure what is the most appropriate size, and you want to make it as big as possible, not too big, but as big as possible that you can get a good fit, and you make sure that you've decompressed the spine. And then you pack this prosthesis, this metal, with bone. Different doctors have different preferences, but what I do in my practice is that when I shave the bone to prepare my end plate, I have a collector on the side, and I collect that bone that's coming from the patient. Then I get that and make it a putty and put it back into this space right here and put it back into the patient. That way, it decreases the morbidity. Once this goes back in, and I tamped it between the bones. Then I secure a plate, as you can see right here. And these are the actual plates that I use. These are the plates that end up in the patient. We measure an appropriate size plate with 4 screws, and these get secured into the vertebral body above and below with 2 screws on each side. Now, we do this plate so that the prosthesis that we put in doesn't get squeezed out like a watermelon seed. Now, of course, there are different preferences between different surgeons in terms of what to do. In the past few years, let's say a decade ago, we used to get the bone from the iliac crest, and that heals well, and that's a pretty good surgery. The problem is that the iliac crest is very sensitive, and 1/3 of the patients ended up with chronic pain in the graft sites. So you did the surgery and they were happy, the neck and arm pain went away, but now they ended up with this back pain or pain in the hip, which is just not that good. So throughout the years, we've tried to shy away from that. Now it's pretty much standard in terms of what we do. We basically use PEEK, and that probably 80 to 90% of the surgeons, we use this. There are other type of prostheses you can use made out of metal, made out of carbon, and of course the PEEK. And this is, the PEEK, the piece of plastic. Pretty much 80 to 90% of the surgeons, this is what they use. It's industry standard nowadays. And then within the next 3 months, the bone grows from vertebrae above and vertebrae below through this hole where we packed your patient's autogenous bone, and these 2 bones through this prosthesis will turn into a solid bone, and therefore that level fuses. And that is the surgery. After it's done, we wash the wounds, we close the wound, and patient awakens. Now, in terms of the postoperative care, there are different preferences. Some surgeons actually they don't use any brace or anything whatsoever because they believe that their prosthesis is pretty strong. I actually would like to be on the conservative side, so I like my patients to wear a brace, at least to remind them that they had surgery. Sometimes, if the patient has risk factors that I believe there's a chance that might not heal the surgery, then I put them in a hard collar, just to be on the safe side. After all, you don't want to do the surgery. After all, you got to understand, you can do a great surgery and great carpentry, but ability to heal this is a patient's physiology, and we don't have any control over it. And there is about 10%, 5% to 10% chance of non-union, which is consistently reported in the literature, that this bone doesn't heal. And if that doesn't happen, which is affected by many factors like smoking, patient's age, bone quality, their activities after surgery, and if that happens, then we have to redo the surgery and get this area to heal, because if you end up with a non-union, the pain comes back and much worse. So the typical history would be the patient goes through the surgery, they're happy, they wake up with the arm pain gone, they feel better within 2 weeks, they're comfortable. 2-3 months after surgery, they're happy, everything is good, and then the pain starts slowly coming back. First is a twinge, then it turns into a full-blown neck pain, and you get some x-rays and you see that this area didn't heal. That's why the postoperative instructions are very important. That's one thing. Now let's talk about complications in this surgery. Of course, every time you do surgery, there are complications. One thing is infection. Every time you cut the skin, you can have infection. Chance of infection in cervical spine is very low. In 9 years of practice, I've had only few times, not more than 5 infections out of few hundred surgeries, and just a simple wound infection because the blood supply for the neck is very good. The other thing would be spinal cord damage, because you are operating on the spinal cord. You can see that's the cord, and you're really going right over the cord and try to decompress that. Chances of that is extremely low, less than 1%. I mean, you have to do something really bad for the spinal cord to get damaged. But I have to, explain that to my patients. Of course, the other thing that's kind of nuisance for the patients, the difficulty swallowing and difficulty talking. Chance of that happening is about less than 5%. And of course, the risk of that increases if you go higher in the level. Let's say when I do surgery in the C5, 6, and C67, chance of that having swallowing difficulties is very low, very, very low. But when you operate around C3-4 and C4-5, especially C3-4, there's a 10 to 15% chance of having swallowing difficulty, because that's where exactly all those structures are. In terms of speech, chance of having a speech difficulty is very low, because even if you knock out a nerve on one side, if the other nerve is working on the other side, we'll be okay. And if there is a difficulty with speech, 95, a good chunk of the patients actually recover. So chances of those is very low. And in terms of surgery in the C3-4 or C4-5, we won't do surgeries in that area unless patient needs it. Beside these, of course, the most important thing, I wouldn't call a complication of the surgery, but the most important thing about surgery is that, just like anything else in spine surgery, nothing is 100%. Chances of the arm pain getting better is about 10% not getting better. So chance of success is about 90% chance of your arm pain getting better, 85 to 90, and chance of neck pain getting better about 75 to 80%. And it's considered one of the most successful surgeries in the spine surgery, one of the most commonly performed surgeries, and it's not very painful. Patients go home the next day. Thank you very much for watching this segment, and we'll talk to you in the next segment for lumbar fusions. Thank you.